I'll just give you a little bit of background on myself and how I'm actually involved with InMode. It's been a really great journey we've had with InMode. It's worked extremely well for us. So I've lived kind of half my life in the States and half my life in Canada. Originally, I grew up in California, in Southern California. My parents were Canadian. We moved back up here to Canada. I finished high school. And then I actually did most of my training in Boston. So I was educated in Boston at New England, and I practiced in Denver for a few years. Then I met a Canadian girl and I married a Canadian girl, and you never leave Canada once that happens. So I live in Canada now. And I have a private practice in Winnipeg, which is kind of right in the center of the country, would be in the middle part of the country. So we started our own practice about 20 years ago. And one of the things that I discovered kind of early on in my practice is, and this is really common with a lot of optometrists, we give out a lot of samples. So we do a lot of things that are, you give a sample of an artificial tear, you give a sample of a lid scrub. And something I discovered very early on, I had a patient, I remember the exact day, this patient came in, had dry eye, had blepharitis. I gave this gentleman some drops, some artificial tears, and I gave him a lid scrub. And I said, okay, take these samples home. I want you to do this for 10 days, come back, and we're going to see how things are. So he did this. He took my samples. He came back in 10 days. And I said, well, how are your eyes feeling? And he goes, horrible, terrible. It's worse than ever. And I was like kind of surprised. I said, really? Like it's not getting any better? And he said, no. And I said, are you using all the products that I gave you? And he goes, no, you gave them to me for free. They have no value. So he felt because I gave him those things for free, there was no value. So he really didn't engage, or he wasn't compliant in treatment. So I decided from that point on, I was going to create a dry eye center of excellence. I was going to try to promote the best possible products for my patients. And I was going to ask them to pay for those products. So if they really believed in what I was saying, they were going to buy into that. And that turned out to be the turning point in my practice. People, if you really want them to be compliant, you should ask them to get the very best treatment for that situation, and they will pay for that. And I think a lot of optometrists are scared to do that. So we started a company in 2012. We have distribution rights to a line of dry eye products. So we sell to a lot of optometrists across Canada. So I have a good relationship with optometrists across Canada because we already have a dry eye company. We sell products to them. So one of the things that I want to kind of go over here is the prevalence of dry eye. Dry eye is an extremely, extremely common thing that you will see in every single practice anywhere in the world. Estimates say, and I'm being very conservative here, 25% of all patients have dry eye, especially amongst the older patients. And one thing to remember is, and Donald Korb is kind of the, the leader in this field. He's one of the ones that originated dry eye treatments. He estimates that 86% of these patients have something called MGD, which is blockage of the meibomian glands. That's a very important thing to remember. The other thing that I want to really emphasize here is there's really no such thing as dry eye. What most patients have is abnormal tear film. They are producing the wrong kind of tear. They have tears, but those tears are highly abnormal and they're actually detrimental to that patient's eye health. So this just shows you charts. It shows you prevalence of dry eye. The chart that's really interesting here is the top chart. And that's over the last 2 years with COVID, people have been on their computers more and more and more. And people don't realize this whole blue light phenomenon and people using kind of a blue filter. The reason blue light is kind of detrimental for the eye is not because it damages the retina. People think it's damaging the back of your eye. What it actually does is it affects your central nervous system and you stop blinking. So if you're reading a book, you're blinking about 22 times a minute. If you look at a computer screen that's emitting a lot of blue light, that goes down to about 6 times a minute. So your blink rate goes dramatically down. That's really important to understand because that is driving the increased prevalence in dry eye in our younger population because they're on electronics an extreme amount. So they're exposed to this blue light. So 20 years ago, I would have never really seen a dry eye patient, let's say in their 20s or teens. Now I see them all the time. So the prevalence is becoming much more dramatic. So I want to do a little explanation of this, the fundamentals of the tear film. So what I tell or what I ask my patients is when patients come in, I say to them, why do we have tears? What is the purpose of tears? And most people will say, it's to lubricate my blink. It's maybe to wash dust off the front of my eye. Those are not actually the real reasons. There are 2 very important functions of tears. Number 1, our cornea, and if you look at this illustration up here, the cornea is this clear tissue that covers the iris. That's where our contact lens would sit on the front of our eye. The cornea is the only place in the body that's completely avascular. There's absolutely no red blood cells in a cornea because you can't see through red. So you can't have blood in a cornea. So the body has a really unique problem. How do you get oxygen to a tissue with no blood supply? And the kind of amazing way the body's gotten around this problem is we have 20 glands, especially the lower lids. You see the glands right here. They're called meibomian glands. We have them in our upper and lower lids. The ones in the lower lids are far more important than the uppers. They probably produce about 80% of the total oily tear. So what happens all day long is these meibomian glands constantly secrete a small amount of oil, and that oil is actually hyaluronic acid. Hyaluronic acid is a very interesting oil because it absorbs oxygen faster than pretty much any other liquid we know of. So the body utilizes this property. It's producing this oil. A small amount builds up on our bottom eyelid. That's called the tear meniscus. So there's always this little layer of this oil. Every 5 or 6 seconds, our top lid, like a windshield wiper, comes down, grabs this oil, spreads it out like a nice tear film there. That oil literally sucks oxygen right out of the air and becomes hyperoxygenated. And it feeds the cornea by diffusion. So number 1, the tear film is there to feed oxygen to the eye, not to wet the eye. It's there to feed oxygen to the eye. And number 2, this opening of our eye is the site of an incredible immune battle. We're walking around in an ocean of virus, bacteria, fungus, mold, spores. We have to kill all of that. And these glands secrete an incredible amount of antibodies into this tear film. So a single drop of tears will have more than 1,500 different antibodies in a single drop. It is a phenomenal immune battle. So if you don't produce enough tears, you're going to create a hypoxic cornea, not enough oxygen. And you're also going to be very predisposed to getting infections. And so these patients will tend to get eye infections extremely chronically. So what really happens in dry eye, and people think of, dry eye as being lack of tears, but really there's not a lack of tears. What happens if you don't produce enough oil from these meibomian glands in the upper and lower lids, your body will talk to the big lacrimal gland up here and it'll say, hey, we got a problem, not enough oily tears. Let's do something. So your body starts dumping salt water down onto the eye, which is a horrible substitution. So patients with dry eye will start tearing a lot. So they come into my office, their eyes are tearing and they'll say, well, my eyes are tearing all the time. What have I got? And I say, you have dry eye. And they say, are you crazy? My eyes they're tearing all the time, but it's actually a form of very severe dry eye. They will have this very abnormal tear syndrome. This lacrimal gland will start to dump salt water down on the eye. Salt water does not provide oxygen and it doesn't protect the eye like that oily layer. So we want that oily layer, that lipid layer to be on the eye. That's all important. Okay, so You can see that the tear film is made up of 3 distinct layers. The oxygen and the anti-infective properties of that are all important, but there's one last very important function of the tears. When you think of the eye, the way the eye functions is our eye is round, because what we're doing is whenever a beam of light is hitting our eye, we're refracting or bending that light to one pinpoint spot in the back of the eye. So what happens is the light is actually being refracted more on the edges than in the center. So we're bending the light, we're making the light focus on an exact point on the retina. So if I said to you, what's the very first surface that's bending the light? You would say, well, it's the cornea, but it's actually the tear film. So if your tear film isn't healthy and you don't have a good tear film, you can't refract light properly. So all these patients will have very blurry vision. So obviously they present to optometry offices in very high numbers. The prevalence of dry eye is, and you can talk to anyone in this field and you'll see that that is a huge problem for anyone who deals with eye care. Dry eye is probably our biggest challenge that we face on a daily basis. So I've just kind of listed here some of the common causes of dry eye. So, autoimmune diseases, there's probably 50 common autoimmune diseases that will cause dry eye. The one that I really want to point out here is rosacea. Rosacea and thyroid disease will cause a huge number of patients to develop very, very severe dropout or loss of their meibomian glands. Obviously there's medications on the market. Lots of people are on antihistamines, birth control pills, beta blockers. These will all also cause dry eye, post-op LASIK, and probably the big one, this is the thing that's driving dry eye in the future, is chronic electronic use. The exposure to blue light is really increasing the number of patients that are developing dry eye. So I want to talk about, there's basically 4 complications that will start to occur when you have dry eye. Number 1, you will start to develop a very significant infection, not of your eye, but of your eyelashes along the lid margin. You start to develop something called blepharitis. Now, for a long time, we kind of assumed blepharitis was an infection caused by Staph aureus bacteria, but those patients would not respond to antibiotics very well. So, we'd prescribe antibiotics, they wouldn't get better. So we started using tea tree oils, lid scrubs, hot compresses. And what we've discovered in about the last 5 to 7 years, this little parasitic worm, you can see one right up here, it's called Demodex. It's a small mite. It is everywhere. It's on everyone's pillowcase. It's on our bedding. Pets have it. We are constantly exposed to Demodex follicularum. It is all around us. Normally, if we have a healthy tear film, we are killing these organisms. They cannot they cannot manifest themselves in our eyelash margin. You can see them right here. You can see when I pulled a lash out and you can see it right on the lash. They're actually quite large. You can see one with a normal slit lamp in the office. You have to be very careful how you try to get them out, and you can see it in larger magnification on the side. In the top right corner, you can actually see where there's multiple Demodex in that follicle. So what happens is the patient will start to get this infestation of Demodex because they're not producing good antibodies into their tear film. They will start to get a chronic infection of their eyelashes. The Demodex produce a type of enzyme called lipase, which is very acidic. It starts to spill onto the eye and starts to burn the eye. So these patients will start to have chronic red eye. But again, this is a complication of dry eye. So all these things happen after you get dry eye. So once you start getting these blepharitis and these Demodex infestations, and I'll just skip ahead here. You can see right here, this is they call this scurf. This is all the debris from the Demodex. This is very common. It's estimated over 80% of patients over 65 years of age will have this to some extent. This, you'll see this kind of scurf on their eyelash margin. It then predisposes you to getting styes, which is now these infect the meibomian glands, and you get a very painful lump. This lasts about 3 to 4 days in your eyelid margin, but that will ultimately lead to, in the bottom here, you see what's called a chalazion. Can you all see the bottom right image where you can see this one is a sty, it's infected. This one now has become a cyst. It's not infected anymore. It's a painless lump in the lid. We call that a chalazion. That has to normally be surgically excised. This is something I've started to treat in my office very successfully with RF and IPL, and I'll explain how I do that later on. Now, just going back one slide, what you see here is a result of lack of oxygen. The cells, or the epithelial layer here, is so hypoxic, the cells will start to die, and you start to get what's called SPK, superficial punctate keratitis, literally like a rash. The cells just start to peel off, and it's like that patient is looking through frosted glass. They simply cannot see through any kind of frosting of their cornea like this. So this is a really big problem for vision. And if it goes on, you'll start to see here, this is kind of end point. You'll start to see these abnormal blood vessels will start to grow, and the cornea will just simply scar over. This is probably the fourth, but the most underdiagnosed and underrecognized condition called conjunctivochalasis. This is a redundancy of the very, very thin film that covers the white part of our eye. There's a thin film called the conjunctiva. It's about 5 to 6 cell layers thick. It's supposed to be as tight as a drum. It covers the white part of our eye. And if you start to get dry eye, you've got an acidic tear. It starts to burn the white part of the eye. Now, suddenly what starts to happen is this tissue gets swollen. It gets edematous. It starts to get a little bit redundant. It's kind of like patients that are overweight. If they're like 600 pounds and they're really overweight and their stomach stretches, and then they get reduction surgery of their stomach and they lose 300 pounds, that stomach, that skin won't shrink back. You've got to cut it out. Well, you can see here that this is redundant tissue. The conjunctiva has become redundant, and that creates very severe foreign body sensation for that patient. So this is something that's very rarely treated in dry eye patients. It is very common, and I think it's something that in the future, we need to find a way to treat this conjunctivochalasis for patients to feel 100% normal again. Okay, so these patients really suffer from kind of chronic foreign body sensation. I've read some articles about how certain surgeons in the US are experimenting with RF, very rudimentary, but they're using it almost at a setting where it acts like cautery. They're not trying to shrink it. But right. What I've tried to do in my office is I've tried with these patients just on my own. You know, obviously I'm using the InMode technology, which is bipolar. And I've been doing multiple, like many treatments of RF over the lower lid to try to see if some of that RF energy gets through the lid to the conjunctiva. The thing I've discovered is the bipolar technology is too good. It's too controlled. It stays within the eyelid. It's not escaping into the conjunctiva. So these patients really don't respond to bipolar RF because it's not getting into the conjunctiva. So what I'd like to see is a device at some point that you could place right on the conjunctiva, especially the inferior conjunctiva. Correct. And you would use RF energy to literally kind of shrink wrap and pull that tight, kind of like a tiny little modified Morpheus Prime that would then deliver that energy right into that tissue, especially at an early stage. You don't want to wait. See this image up here where you see the fold starting to develop? That would be a perfect stage to try to do a very, kind of really easy type of RF treatment. Don't let it get to this where you need to do a resection down here. Those resections are horrible. It's extremely easy to diagnose. All you have to do is put fluorescein on. So I just put a little bit of fluorescein dye on here, and you can see these folds happen very quickly. You don't need a special diagnostic piece of equipment to do this. You can simply see it through the slit lamp, and the prevalence of this is, virtually every single patient that develops, and I don't want to use, I don't like using the term dry eye. I prefer calling this abnormal tear syndrome. When you start to get the acidic tear, you start to get inflammation of that conjunctival surface. When the conjunctival surface gets irritated like this, the redundancy happens very, very quickly. You'll start to see these folds happen really quickly. You know, really, we try to ignore this and hope the patients don't complain about it, because to go in for this surgery, people dread this. And when they come out of it, they're very miserable. They're not happy with the outcome because it tends to create scarring underneath. They try to do it under the lid, and those patients are very unhappy. As far as discomfort of the patient, conjunctival chalasis is probably 80% of the discomfort. Because when they start to get the redundancy of the conjunctiva, they have chronic foreign body sensation. They will come in and say, there's something in my eye, please get it out. And you have to understand this in context. If an eyelash landed on the back of my hand, there's literally no sensation there, but you get one eyelash in your eye. If I said to you, I'm going to put an eyelash in and I want you to sit with that in all day long, you'd be like, that's crazy by the end of the day. So these people live with that kind of chronic discomfort, and you tell them, hey, I've got a procedure I could do here in the early stage and get rid of this problem. They're going to self-pay for that in a heartbeat.
Mishka, this is what I was trying to talk with Roy Chuck over at Mount Sinai, but he was coming at it from a different.
I have a question. How does conjunctiva react on some damage, mechanical or thermal? Is it scarring or just because, you know, for example, if you do some fractional ablation or something, does it, if you do some damage, it creates some maybe microscarring that it's actually became even worse than before because now you have some harder tissue scratching the eyes? How it reacts on the any external damage?
The conjunctiva, from my experience of seeing post-cautery patients, gets very badly scarred. So they're trying to do some more advanced ophthalmologists will try to do grafts. They'll try to graft tissue in there to try to make it feel less uncomfortable to that patient. But the vast majority of the ophthalmologists that I've seen post-op, when they do this, they just simply do the cautery. They leave a very nasty scar. It reacts very poorly to that heat. And it contracts, but it leaves a scar. And that scar usually has a very defined ridge to it. So, when you're blinking, you're feeling that ridge of scar tissue. So it's a terrible solution for the problem is cautery. I think if you could, I think you need to treat this in a way that's going to, done slowly with RF, like multiple treatments where you can slowly tighten on a very slow and not cause scarring. I think that would be the pinnacle of treating a condition like this, and get to it early. Don't wait till you've got late stage, severe redundancy. Just like anything, and I'll talk about this a little bit later on. Yeah, just like any eye condition, you got to treat it early.
Mishka, this more goes along the lines of the collagen, of the cartilage remodeling we're doing with heat.
How I see that, you have this wrinkled conjunctiva. Right. There is two ways, just maybe to try to reach deep enough from outside or from inside and warm it to try to tighten it, or maybe to come, let's say, with some fraction of from outside, come close, but not to cross conjunctiva, and just, for example, stop 1 millimeter before the end and try to tight skin. But if you tight skin, probably you have this excessive conjunctiva and you get probably more wrinkles. So,
Bruce, here's the really
maybe I approach what Bruce said, that Bruce, just slowly, gradually to tie it all together without like damaging. Maybe it's
Bruce, is this analogy correct? And sorry for all the dumb questions.
No,
you have the conjunctiva, right? If the conjunctiva really is doing this, it's sort of like there's a curvature to it, correct?
Yes.
Right. So if this is a sheet, a bed sheet, which is over this tennis ball or basketball, sort of say,
exactly.
Right? If we grabbed the periphery of this sheet and tugged it, right, that would be sort of the way to do it. Right?
Exactly. Stay away from the cornea.
Stay away from the cornea, hit the periphery and tighten that sheet over, like over this basketball or baseball, whatever, and do that and see gradually how that works. If you over tighten it, is there an issue if it gets too tight?
Not really. No,
No.
it needs to be tight.
It needs to be tight.
It needs to be tight, and there are functional cells within the conjunctiva. We have to be careful because there are goblet cells and they're called Wolfram cells of Wolfram. They secrete a little bit of the mucin, the really viscoelastic layer of the tear film, but it wants to be tight to produce that properly. When you start to get a redundancy, you start to get excessive amounts of that being produced, which is not good. And you get like the patient will wake up with gooey stuff all over their eyelashes because it's a very cosmetically very unappealing look because they always get this debris. It's like wet sleep always coming out of their eye because of this redundancy. But where I see the person being treated is in the fornices. So the pocket, if I pull my lid down, there's a pocket, an inferior fornix, and there's a superior fornix. So you'd want to treat in the fornix away from the cornea, tighten it down there. It pulls it just like you're saying, tight like a sheet.
Pull it down.
Yeah.
Pull it down. And that group is pretty safe anyways.
It is. It's very safe in the fornix.
I have some stupid question. What is under the cornea? It was like ball of liquid?
Under the cornea is aqueous. So aqueous humor is very liquefied. It's a liquid that's just like water. And
this is like free water. It kind of has some.
It's circulating.
Circulation, like all kind of. So when you treat with forma I, basically this water bag just suck heat out and not allow to hit the conjunctiva when you treat from outside. Is it correct?
Sorry, I didn't understand the question.
When you treat it with air from outside, and you say that conjunctiva is not warmed up enough, and probably reason because eyeball take all heat like out. It's so if you put some plastic eye shield, not metal one that is suck even more, but plastic eye shield, but isolated from the. Is it possible maybe to reach the much higher temperature on conjunctiva and reach this tightening? Because I would say where I'm coming from, we have some devices for gynecology very dramatically. So like in vaginal treatment, we do similar to what we do with forma I. And after 10-15 meters, you feel that you cannot move it anymore because it's like tissue catch it, just
right.
Tight. So, and I think if we can put some plastic eye shields above the cornea and heat it, maybe we can reach a high enough temperature and maintain it to get this contraction.
Yeah, I mean, that would be great to protect the cornea. And think about what they're doing now. They're taking a cautery. It's like a red hot.
I understand. It's like create scarring and you have already permanent foreign body on the.
Bruce, let me ask you a question. So you mentioned prime. I mean, the distance to get into that fornix from externally to internally with microneedling, it's less than 0.5 millimeters, right?
Oh yeah, it's about 5 to 6 cell layers thick, the conjunctiva.
Right. So for us, hold on, Mishka, hold on. So for us going externally, what I mean, the distance from the skin to hit that fornix, if you retract everything down and hit that redundant tissue right in that area, if you're coming from out in, it's a very
through the eyelid.
Correct, through the eyelid.
No,
okay.
But hold on, Mishka, hold on. Through the eyelid, these needles are coated, so you're not having any heat transferring through the lamella or below or anything like that. You're only hitting it at the tip once you're located in the fornix over that conjunctival strip. How hard can that be to do that?
I think that's very doable. And plus you could, the thickness of the lid is pretty, unless the person has a lot of lid edema, the lids are pretty uniformly a certain thickness. Yeah. You could calibrate this to go only a certain depth. It would go through the lid. It would reach just to the superficial part of the conjunctiva. You would be away from the cornea. That's the beauty of this. You do it in the fornices. You'd get away from the cornea. The key is we look through our cornea. You cannot damage the cornea.
Yeah, of course.
So as long as you stay away from that, I think this is all very, very doable.
I mean, if you have a corneal protector and you're pushing everything back, this redundant conjunctival tissue is going to be down there anyways. You come externally with the device, heat only at the tip, where you need to determine that depth from the skin all the way down to that conjunctival excess tissue, and just hit it and shrink it.
Right.
We don't have to develop something to go inside.
You have to stop some distance from conjunctiva just to hit it, but not to coagulate or ablate it. Otherwise, you will get some microscarring. So you have to. I've been in many blepharoplasty and measure all the thickness of eyelid, how thick it is. It's 5-6 millimeters from the skin to conjunctiva.
5-6 millimeters?
Yep. From here, dermis is very thin. It's like dermis about 0.5 millimeter, but then you have fat layers about 1 millimeter. Then you have muscle layer. Then you can have fat layer. Then you have kind of collagenous layer.
I think it's a lot less.
You know, just it's like bacon. It's like bacon of many layers.
If you're going through the tarsal plate, if you're going through the tarsal plate, yes. If you're not, then no. It's a lot less. It's a lot smaller distance, I think, Bruce. Well, regardless,
it is, but you'd have to go through the tarsal plate. Like the way I understand you're proposing, we would have to actually go through the tarsal plate.
Correct.
Just like, you know, what Michael's describing, the layers are quite thick. It's like a sandwich, all these different layers, and you got to go through them all to get to the conjunctiva.
You think it's 6 millimeters, Mishka?
I measured like a bunch of them, like at least 6 patients. I measured different patients. I measured between 5 to 6 millimeters.
Well, the good news is, Bruce, that they're using bovicautery at 1,000 degrees Celsius.
Yeah.
So with our needles, you know, in our heat, which is basically heating at 80 degrees, it's a lot safer. So we have a large margin of error there, provided we don't hit the cornea. Right?
You bet. As long as you're staying away from the cornea, it is infinitely safer than the kind of heat they're using for cautery. The papers that I've looked at, you know, where they've tried using RF, they've applied the RF directly onto the surface of the conjunctiva. So they put a lid speculum on this patient. They've just ripped those lids right back. They went right on top with a little probe right onto the conjunctiva to try to apply that, but they're applying it in very high energy.
So, but
it looked very rudimentary.
But Bruce, we could do the same just for proof of concept to see what kind of shrinking we're getting on the conjunctiva with our needles before we start going through all these layers.
Yeah. I think some like.
Just understand what he's saying? That we set everything up just like we would with a bovicautery. Open everything up, but instead of using a bovicautery, we check what our needles and our heat does on that conjunctival tissue before we go through all these other layers. Just straight on to see, does it shrink? Does it not?
You want from inside to come from inside on conjunctiva?
To come from inside to see if it works. What does it do?
I just directly afraid that you create some microscarring on conjunctiva. It's make it, instead of like extremely smooth mucosal layer, you create some roughness.
They're already using a bovicautery, unipolar bovicautery, and the scatter from that heat is tremendous. So this is way safer. Anyway, you got it, Bruce. Sorry to interrupt. I mean, I think but this is sort of an application which stands out immediately because it's all about skin shrinking, collagen shrinking, mucosal shrinking. We're the shrinking, you know.
You guys are the kings of shrinking. I agree. That's
right. So
that's why I even bring it up. And you know, as part of the
before we do any Morpheus or any microneedling there, I believe the best is to start with non-invasive, something similar to the iForma with protection on the eye and going all over the eyelid from the outside. If the depth is something like 2-3 millimeter, you get right to the point and you can tighten it. And the plastic cover of the cornea will protect the eye before we punch it. Mishka, what do you think?
I think it's to deliver energy deep enough, or we just warming slowly whole eyelid and put plastic just to create all
that's what I meant. That's what I meant.
Warming up. That's one option. The other option is to go with needles, but not to go to the end, not to like stop, I don't know, 1/2 millimeter from the conjunctiva and dramatic tightening inside and some tightening outside because it is some heat spread around.
I mean, look, who's doing these procedures, right, Bruce? These are surgeons, right, who are doing this conjunctival
Yes.
sort of shrinking.
Ophthalmologists are doing this.
Right.
Yeah,
So
only
we start off with those guys, and then we can always dial it back. You know, I mean, we kind of look at what they're doing with that and everything. So
Just if I could just suggest one thing. When you look at the eye and the eyeball, the conjunctiva reflects from the inside of the lid. It reflects back and goes up onto the eye. So it creates a pocket. So the conjunctiva that's on the surface of the eye is continuous with the conjunctiva as it reflects on the back part of the lid. So my thinking is if you went in and you actually caused, they call this it's the bulbars on the front of the eye and the fornical conjunctiva. If you shrank that, it would pull it all the way down around.
Right,
and
it's like pulling the sheath from below.
That's right, but without actually touching the eye.
Without touching the bed.
I suggested at the beginning to do dramatic tightening around to pull it down.
Yes.
Plus, you've got a happy patient because you probably got rid of all their wrinkles around their eye. They're going to be like, that's super.
Yeah.
Wrinkles, eye, whatever we can remove.
Yeah, but let's continue with the dry eye. We can discuss that in a separate.
This presentation, yes.
Yeah, otherwise we will not.
Thank you, Bruce. Sorry about that.
No problem. So I want to get back to, and I'm just going to give you, in my opinion, there are two basic ways you get dry eye. Number one is autoimmune. You have some kind of autoimmune condition, especially arthritis, rosacea, thyroid disease. When you have an autoimmune disease, your body fails to recognize that collagen is normal. It wants to kind of attack collagen. So anybody with autoimmune disease will ultimately end up with dry eye because the meibomian glands in the bottom lid are almost entirely collagen. They are extremely fragile, and you will start to see dropout. The glands start to get destroyed by this autoimmune condition. So that's kind of mechanism number one. The second mechanism, which is the very, very most common, is blockage of the gland. And that's called MGD. And what's happening here is literally the meibum as it moves up. So the meibomian glands, think of them as being like a long straw with all these little glands like clusters of grapes. They're feeding into this long straw as it comes up. At the very bottom of the gland, there's a little bulb, like a turkey baster. And every time you blink, the exact pressure pushes the meibum up. Every blink pushes it up. So the pressure of the blink is very important, pushing the meibum, the liquid kind of olive oil tear, up through that gland. So if you don't blink enough, if you're on a computer all day long and you're blinking 6 times a minute, what starts to happen is the glands just stop, everything stops moving. It becomes kind of static. Things start to get a bit, it's an oil, it gets rancid. It turns into kind of a yellow wax and it literally plugs the gland. And this is incredibly, incredibly common. Probably 85% of all dry eye patients have this. If you leave the gland blocked long enough, it will simply atrophy like anything. If it's blocked for many months or years, the gland starts to die from the bottom up. So remember, those are the two things that I'm really trying to treat on a daily basis. Okay, this is just going over, we have new diagnostic, we have machines now that we can do all these diagnostic, very comprehensive pre-treatment values, and then we can compare what the values are before we do the treatments to after. It's very valuable to show the patient. So this is the battery of tests that we run. Every single patient gets this baseline. And you can see these devices are very good at measuring. They can kind of identify the gland in upper or lower lids. We can image them and we can measure any dropout. So this thing will give me a percentage. This is 18% dropout of the gland tissue here. So it'll show me kind of how much loss of tissue there is. And this other one here is called the non-invasive tear breakup time. There's a lot of different ways to measure how much tears. And one, the ophthalmologists have a way different way of looking at this than optometrists. Ophthalmologists put Schirmer strips and they put all kinds of fluorescein dyes on, and you're now adding liquids or irritants to the eye and you make it tear, you make it look different than it actually is. So whenever I measure tear films, I use a non-invasive method. I don't want to touch the eye. I don't want to put a drop in the eye before I measure how much tear is there, because I want a true measure of what's actually there. So we can measure the meibomian gland right here. So just looking at this with the laser pointer, we can measure meibomian glands before we start treatment. We can measure how much tear they're producing. We can measure the tear meniscus. There should be a little layer of tear continuously on the bottom lid. And we can do fluorescein and we can look at how much staining is on the surface of that cornea. Okay. Now, there are two basic groups of optometrists that are doing dry eye. There's reactive optometrists and there's proactive. Reactive means you wait for that patient to walk in, they're in agony, they have late stage dry eye, they'll tell you my eyes kill me, they're using all kinds of drops, they're not happy. The problem here is you've got a patient that's at very late stage. This is not an easy patient to treat. My belief is that as optometrists, we need to start to become very proactive. That means we need to screen with diagnostics every single adult patient that comes in to diagnose them early. Like any eye disease, if we see glaucoma early, we treat it early. You see MD early, you treat it early. We should start to do this with dry eye. And I think when you start doing that, and I think that's the reason my practice has been very successful, is because I've been able to identify patients who are asymptomatic, treat them while the condition is very minor, get rid of the condition before it becomes a problem, and those patients never end up having severe problems. So that's something that I try to relate to my colleagues, that if you start doing that, you're going to be way ahead of the game. And I want to give you proof of what I mean here. These are two patients in my office. Both of these patients were teenagers. Okay. So the patient here on the left, so this is the gland images. You can see his glands right here. They're perfectly normal. Okay. This is his non-invasive tear breakup time. He's got an excellent tear breakup time of about 20. This is very normal. So this was his baseline scan. This girl right here was about 17 when I first saw her. She came in with her mother. Her mother was a physician. They knew she had dry eye, but they didn't know kind of how bad it is. You can see the severe dropout of her gland. She maybe has, maybe 10% gland tissue left there. Very, very severe. And when you looked at her staining, you could see the epithelium was literally peeling off. All these little dots there are spots where the epithelium is dying. It's hypoxic and it's literally peeling off. And her non-invasive tear breakup time on a scale of 1 to 20 was only 5. She was like 17, 18 years old. And she was in a lot of pain. She said to her mom, I don't want to go to school anymore. I go to lecture hall. She was starting university engineering. She couldn't go, too much glare, couldn't drive a car. Her mother came in, who was a physician, and said, I only want Restasis. I want a prescription for Restasis, which is a drug that's used to treat dry eye. They put her on Restasis for a couple of years. She came back to my office 2 years later and said, it's no better. It looked exactly like this. In fact, her corneal staining was much worse when I saw her 2 years later. And I suggested two things. I said, we're going to do RFIPL, and we had phenomenal results with her. But I said, we need to go get blood work done because she has an autoimmune disease. And she was actually diagnosed with JRA, juvenile rheumatoid arthritis, after. And her mom just kind of ignored, she just assumed, well, she's okay, she's healthy. But a lot of these patients have autoimmune disease. So, there's a lot of things on the market right now. Lipoflow's out there, Miboflow. There's a lot of, mechanized or automated gland expressions. There's a lot of medications coming out on the market. So really, I break down dry eye treatments into only two categories. You're either treating dry eye medically, you're putting Xiidra, Restasis, Lotemax, steroids, artificial tears. You are asking that patients to be on a lifetime of drops. It is very expensive to be on these medications. Xiidra in my province would cost you about $2,500 a year. You'd be also using artificial tears when you're on Restasis. That's probably another, $500 a year. Patients like this are spending minimum $3,000 a year for the rest of their life. And doctors, when they worry about charging patients for procedures like IPL or RF, they don't think about the cost that patient has if you write the prescription, because that patient's paying money too. They're just paying it to a pharmacy. So there's the medical model. And to me, there's now the procedural way to do it, which is IPL, RF, and manual expression. And what I've done, over the last 3 years, as I've started to combine these. So just to give you an idea of the efficacy, Restasis only has a success rate of about 30%. And I'm being charitable there, 30%. Because remember, 85% of people have MGD. They have a blockage. So if you put an immunosuppressive drug on that patient's eye, nothing happens. They don't get better. It's a blockage. So Restasis and Xiidra are widely used in North America, but they're not approved in Europe. They're not approved in New Zealand, Australia, and a lot of countries in the world because their efficacy is very low. The other way to look at it is the Mayo Clinic did a big study, and the Mayo Clinic did a study, and I was really glad to see that they did the same thing I was doing. They were combining RF, IPL, and gland expression, and you can see they had really, really good results. And I would say that my results in my office are very similar to this. When I treat dry eye, my success rate is between 85 and 90%. And we track this very closely. We do all the baselines on every patient. And then we do a follow-up after, 20 weeks when everything's done. We do a comparison between their entry values and their exit values to see, did we really move the needle for these patients? So, I'm really happy with my results. And I'll tell you this, people with chronic dry eye, they keep coming back to your office complaining. So you want this treatment to work. So I think a lot of doctors dread writing a prescription for Restasis. That patient comes back in 6 months and says, my eyes are killing me. This isn't working. Doctors don't like that. They don't want that, because now what do you do? So to me, in eye care, especially here in Canada, there's a real paradigm shift. I think we're shifting away from the medical model to using more of these treatment models where we're using IPL, RF, and manual gland expressions. And I'll kind of go over the way that I treat this. Now, what I love about using the InMode technology is that you guys have this bipolar RF, which makes it extremely safe for the cornea. That is a big deal, because when you're doing these treatments, a lot of times you're treating upper lid. And if it's not safe on the cornea, or if you have to put a shield on, it takes a lot more time to do that. So I think that makes this almost ideally suited for eye care. So if you look at this list right down here, these are the things that I treat in my office. So I've kind of taken this technology. I see that it has great applicability to the eye, and I'm treating, obviously rosacea, MGD, blepharitis. I treat a lot of patients. Instead of using Blefex and kind of the old-fashioned treatments, I offer them IPL specifically to treat their blepharitis. And patients will pay for this. They have this so chronically, they will pay to have this only for blepharitis. So chalazions, and I'll show you this in a case study, fine lines and wrinkles, these are all, there's a lot of applicability here, okay? So obviously, you guys know all about this, Dr. Toyos, Dr. Perryman in the States, IPL, really reds and browns. So when we're dealing with dry eye, what you will see in the majority of patients, when you look at them with a slit lamp and you look at the margin of their eyelids, they will have a lot of very small neovascular blood vessels. Neovascular blood vessels are leaky. They leak inflammatory cells, and they cause lots of damage to the meibomian glands. So by using IPL, there is no doubt that we can break that inflammatory cycle. So when I'm talking to patients, I tell them, when I'm using the IPL, what I'm trying to do there is stop the inflammation. That's one part of the treatment. When I'm using the RF, it's a little different. I'm treating deeper. I'm using that for bulk heating. I'm trying to melt the meibum, express the meibum, and I'm also getting some neocollagenesis. I'm getting some of the collagen. and I'll show you some images here of my meibomian glands. I'm trying to grow that back or get it functioning better. My goal is always to get you producing your own tears. I want to get people off of drops. So that is always my fundamental goal, get people off of their drops. So here I'm just showing you kind of a few examples. I have to treat rosacea an awful lot in my office. This is a good example of a patient here who had bad rosacea. You can see when you get this, as far as eye complications, this gentleman, his rosacea is so bad, he has no eyebrows, he has no eyelashes. He could no longer grow a beard in any way. His follicles are being very damaged. And you can see after only 4 treatments, he was doing much, much better. His dry eye was almost resolved. And you can see that we've gotten rid of a lot of the really severe neovasc that he had in his cheeks. And the beauty of using IPL on the eyelids is the Demodex, or the small little mites that infest the eyelashes, have a hard exoskeleton. And when you apply IPL energy, that exoskeleton really absorbs the energy, and you literally just incinerate them. You fry them. So there is no better way to get rid of Demodex than to do this procedure. And I do 3 treatments with a patient. I'll put a shield on them. I do the treatments about 2 weeks apart, and I'm doing upper and lower lids. Okay, so this is just Fitzpatrick scale. You guys know about this. So these are the shields that I typically use in my office. I use the Yamamoto shield up here for a lot of patients when I'm only focused on bottom lids. And then I use these stainless steel shields when I'm doing patients' upper lid. And I'm doing upper lids quite a bit. This is just the steps here. And this is just showing all the different, periorbital. Obviously in eye care, we really focus on that immediate orbital area. So this is just showing, when I'm using the regular handpiece, and I'm doing only lower lids when I have rosacea patients, this is typically how I apply the energy, kind of in a horizontal fashion like this. We'll go several passes like that. And this is a good example. Optometrists don't realize how much aesthetics there is here. Like this gentleman, after he saw the results he was getting, he was very impressed with this. He kept going on so that he could get rid of the rosacea. So a lot of my dry eye patients develop into a patient that now will pay for aesthetics, because, the results you get, especially on rosacea, is phenomenal. We can really help out these patients from a cosmetic standpoint. So in my office, I have both Forma Eye and Forma, because we do quite a bit of full face treatments. And the bipolar, the beauty is here, I can do RF on these upper lids, and I have my staff doing all my RF for me, and it's super safe, and I never have to put a shield in. I've done almost 1,000 procedures in my office now, and I have never put a plastic shield on a patient to do RF on their upper lids. And some of the competitors in Canada, Cynosure and some of the other companies, are trying to, go to these lectures and saying, you have to put a shield on the cornea. You must put a shield on the cornea. And the reason for that is recently there was a study done by the University of Waterloo here in Canada. And that college had been advocating for doctors to ask patients to go home and do a hot compress on their eyes, 15 minutes. And immediately after they take the compress off, they ask them to do a digital massage with, just their finger, push on the, like, in a way trying to massage the glands to get them open. And the study discovered, because you're putting heat on an avascular tissue, it's just pure collagen, and then applying pressure immediately, it was warping the cornea and causing keratoconus, which is a very serious corneal complication. Mm-hmm. So Waterloo sent out this immediate kind of newsletter to their, people graduating, don't ask people to do this anymore. So Cynosure is kind of having to put that shield on because they use monopolar, and they were saying, well, InMode's got to use it too because it's not safe. So, what I had done was I had done a baseline, we do a mapping of the cornea before we do the treatments, and there's absolutely no change in that corneal topography pre and post treatment. So I'm very happy to say we've never had any problems doing that bipolar RF on upper lids The corneas have never seemed to be affected, which is, I'm really happy about that. So, you know, the beauty is when we're doing this RF, we're getting the glands to about 42 degrees. That is the magic number for opening up the glands and getting a good expression, is 42 degrees Celsius. So here's some examples of the neocollagenesis. So here what you're seeing is a pre and post treatment of a patient. And it's a slow process, but you can see that what happens to the glands is when they start to atrophy, it's called ghosting. The glands just flatten out. The tube that, you know, that kind of supports that gland, like there's a long tube here, right down the middle, that flattens out and it looks like it's disappeared, but it's really just ghosted, and that gland can come back. So you can see between starting and our follow-up here, you can see the glands start to elongate. And I'm really starting to follow patients. I really want to follow the progress and see if we can really get some substantial evidence that the glands will actually grow back. So this is just an animation. You guys created this for patients, but it really shows how when we heat the glands, it's really critical we get that 42 degrees. So we always set our cutoff at about 43 degrees. So we get 42.5 degrees, and we can express this very easily. Okay, so I want to describe to you kind of the evolution of how I've treated my patients. So obviously, when we first got the device, we had no experience, and we were told never combine RF and IPL, never do them at the same time, separate them by several months. And then I visited a friend of mine who's a dermatologist, and he was showing me some interesting things. He was saying, when we treat patients with IPL for, let's say, rosacea, we put the patient in front of a heat lamp and we get their face a bit red so that they're flush. And then the IPL, because it's absorbed by red, it works better. You get a better outcome. And I'm gonna just move forward here for a second. And I discovered when we do, sorry for just jumping ahead. I'm just trying to look for, here's an example of me doing Forma on a patient. And at the end of this video, what you're gonna see is that below the eyelids, the lids get really nice and red. So they get very flush. So what I started doing was thinking, we've got now, it's a bit edematous, it's red. Now, if I do the IPL on top of that, I'm gonna have the maximum effect. So when patients come into my office, I combine those treatments. I do RF followed by IPL, and then I do a gland expression. So, basically my technicians, they all do this kind of C pattern RF. So they start by prepping the patient. Usually they'll go 3 or 4 passes on the bottom lid per pass on the top lid. So the bottom lids are far more important because that's where about 80 to 90% of the meibum is produced. And then after we do a gland expression, after we've done RF IPL, we do this gland expression.
Gland expression after InMode.
This is a little video my staff made of me doing expression. You can see how waxy the meibum becomes, and it's just plugged. So you've got to get that open. So it's very important that you open up the glands with this expression. So you can see that when these glands get plugged up, there's no way you're getting the normal oil expressed onto the surface of the eye. So this is a classic example of MGD. So this is the majority of the patients that we're treating have this MGD condition. We're doing this on every patient. I always do manual expressions rather than LipiFlow. LipiFlow is an automated method of expressing, where you put a device on the eye and it heats the gland and it kind of pulses slowly to try to express the gland. The reason I don't like LipiFlow is it's always at a set pressure. You can't adjust the pressure, so you can't really modify that or customize that for the patient, and they all vary in how much blockage there is, and you don't see what's happening. I want to see what's happening. I think the expression should always be in the hands of the doctor. The doctor should be doing this manually behind a slit lamp, and when you do it that way, you can track from treatment 1, 2, 3. You can kind of follow the progression, and you know exactly how much success you've had in opening up the glands. So teaching or training doctors, especially eye doctors, we're not used to using these kind of techniques on how to do this. This is an example of a patient where they did, using a 515 handpiece, they did some samples on a rosacea patient, and you can see they got the little bit of bleeds here. So, I do a lot of training of doctors that have bought, let's say, InMode devices. Almost daily, they'll call me and they'll ask me, how do I get started? What do I do? So periorbitally, we're just kind of learning what is the best way to do it. So this is my standard treatment here. This is what I do on the majority of my patients. We're doing a treatment, usually 4 treatments. We're doing these treatments every 4 weeks. We combine Lumecca and Forma I with manual gland expression all at one visit. The patients will go home and they'll do, between treatments, a moist heat compress. They'll use some kind of, a really mild ointment on their skin, omega-3 supplements, and we have them use an eye seal because a lot of patients have lagophthalmos. They won't completely close their eyelids when they sleep. So we have to protect that cornea, that little gap overnight. So a lot of patients will wear an eye seal overnight. So this is just, from the lecture I did in California. I was just showing some of the trainers my settings. So this is the settings for the Forma, 20 degrees, cut off at 20. This is just me doing a Forma there on a patient. And then Forma I, pretty much universally, my energy is at 5 and I have a cutoff at 43. 99% of my patients tolerate this extremely well. The odd time I have to reduce the cutoff energy to 40, it is very rare. I think I've had 2 patients in about the last, year that I've had to decrease that. So that's kind of my standard setting. This is the technicians. They're doing my Forma eyes before I get into the room. So you can see this is kind of the method we use is the CPAS. And so my settings, I'm typically, and obviously the Fitzpatrick scale is very important to determine where that patient stands, but this would be an average setting that I would start at. I'd start at about 12 joules, strong cooling, long pulse width. Every treatment, I incrementally increase energies and settings so that I can get more efficacy as I go along. So here this is just showing me, put on the Yamamoto shield. This is, we use this about 50% of the time. We use this type of shield and we do lower lids only, but the majority of patients, I'm doing upper and lower lids because a lot of my patients, they're quite severe. So again, I put anesthetic on the eye first, and then we put an ointment inside the shield and we place that shield on the eye, and we can do upper and lower lids very effectively this way. Here's, this is how I always start with the spot IPL. This has been absolutely genius. I love that you guys developed this. I put this on. So what I always do is first, I do 2 passes with the spot IPL, and I'll show you here. I do 2 passes on the upper and lower lids, and I go very close to the lid margin. When I'm using the regular handpiece, I've got to be careful. I've got to be 2 millimeters away.
Yeah.
But I've discovered I can go, excuse me, I can go right on the lid margin, virtually adjacent to the lashes without causing any problems. And I've done quite a few patients this way. I find that I have to increase the energy. So if I'm using this spot, I usually go up about 2 joules of energy. So if I would be using 14 joules with the regular handpiece, I'd be using usually 16 joules with this smaller spot IPL to get the desired effect. And I find that works quite well to increase the power a little bit on this spot IPL. The spot IPL, I do 2 complete passes, upper and lower lids. And then I come back and you'll see in my next slide, then I do another series on the lower lid with the regular handpiece.
Oh, okay.
And I do 2 passes there. So the lower lid will literally get 4 passes if you count them all. 2 with the spot and 2 with the larger handpiece. And this is me just doing the upper lid. You know, I just turn it horizontally. I just do 2 on the upper lid. Again, the upper lids aren't critical. You know, a lot of studies have been done on which glands are most important. And we even know from the midline nasally are more important than midline temporally. On the lower lid are the most critical glands to treat. The glands are they tend to be longer. And so I guess the anatomy of that, plus the pressure of blinking is more on the bottom lid. So because of that pressure, it's pushing on the bulb at the bottom and pushing more meibum up. So the production is much, much higher than you get on the top lid. Here's an example of me doing manual expression behind a slit lamp. I've put, 1% alkane into this patient's eye, and I'm putting quite a bit of pressure here with that tweezer. So, you have to squeeze quite a bit to get these glands to open up. So, it is a little uncomfortable. I always freeze the patient, but I take every opportunity I can to open up those glands. Okay, so I'm just going to go through very briefly. I'm going to show you 3 very common types of patients every single optometry office will see, every office. This is patient number 1, 50-year-old female, dry eye, very prevalent with females. She's on a computer all day long. She can no longer wear her contact lenses because when you get dry eye, the first thing that fails is contact lens wear, because contact lenses are sponges. They suck up your tears. So you can see that she'd been on Restasis, no real effect there, didn't help her at all. Her non-invasive tear breakup times were 6 and 8, which are terrible on a scale of 20, very, very poor. So when we treated her, her tear breakup times improved immensely. They went from 6 to 13, 9 to 15. So you can really significantly improve the amount of production of meibum that you get from those meibomian glands. This patient, I took her completely off Restasis, and she just uses, artificial tears, kind of as needed, so that's a big success. So I'm just going to show you a couple quick things. So here's this, these are right eyes. And if you look very carefully at this meibography, you can see some background inflammation. See how it's kind of dark here? That's the immune system she's got blocked glands. They start to get inflamed. After we do the treatment, you can see the glands there on the right lid. You see they're much healthier looking. They start to elongate slightly. You don't see the background inflammation. And here on her left lid, you can see acute inflammation of the glands. You see loss of gland tissue, and this is post-treatment. The glands look way healthier. They've elongated slightly. Inflammation's gone. So these treatments make a big difference